Tonight we're here to honour past, present and future researchers, and the theme for our 70th year celebrations is empowering researchers, transforming lives, and that's what that $100 million worth of research funding has done. So I just wanted to have a thank you to all those who have made it possible. To some of our donors here tonight, you have contributed so much to making researchers do what they do best, medical research. To the Goodfellow family. So for those of you who don't know, Sir William Goodfellow was very involved with the start of our organisation. Douglas Goodfellow contributed significantly through his lifetime. And then the Goodfellow family got together and made a benevolent fund. And that fund actually covers all of our administration and management costs. So my promise to you is that 100% of your donations goes directly into the cause, and that's funding medical research.
It gives me incredible pleasure, both as a representative of the Medical Committee and the Board of the Auckland Medical Research Foundation, and as a public health medicine specialist and epidemiologist, to introduce Professor Diana Sarfati to this audience. We are going from the individual care of a patient through to the care of a whole population. Diana was an amazing epidemiologist before being an epidemiologist was sexy. And she's done an amazing job at transforming the care of our patients with cancer, taking a population perspective, applying the skills of epidemiology, not just to understanding the burden of disease, inequities in disease, but actually what you can do about it. And one of the wonderful things that I greatly admire about Diana, which I'm sure we'll be hearing more about, is how she's traversed from the ivory tower through to supporting the establishment of Te Aho o Te Kahu, the Cancer Control Agency, through to being Director General of our whole country's health system. So please join me in welcoming Professor Diana Sarfati to the stage. Thank you.
Kia ora koutou. Can everybody hear me okay? Look, thank you so much for inviting me to speak today. It's a great pleasure to be here. I'd just like to start by congratulating the Auckland Medical Research Foundation on giving out $100 million to research. What an extraordinary achievement. I was a researcher, I still am a researcher really, and so, you know, I know how much that means to researchers, but more importantly, what that means to people who are using the health system in New Zealand, which is pretty much everybody. So congratulations, it's fantastic. Now, I am going to be doing quite a different kind of presentation from the one that you just heard. As you heard, we've gone from like a single individual patient and the extraordinary groundbreaking work that we heard from Richard, and I'm actually going to be starting on a global scale, so I'm going from one extreme to another. So I've called my talk The Changing World of Health, or Changing the World of Health. And what I mean by that is I'm going to do a talk in two parts. The first one is really highlighting the challenges that are driving the changing world of health that we all live in at the moment. And the second part is my journey as a health researcher who aimed to, in a very, very small way, change the world of health and kind of what I've learnt along the way. So I quite like this slide. This was from a couple of years ago when COVID was a little bit more at the front of mind. But this is showing, a city somewhere in New Zealand dealing with health reforms and trying to get the health reforms in place with these major global mega trends bearing down. So we had COVID-19, various healthcare disruptions, economic, political recessions, climate change. And so those are some of the sorts of things that I'm talking about when I'm talking about the challenges that are facing not only our, but every health system in the world. So I thought I'd go through some of those. The first one is climate change, and we don't necessarily think about climate change when we think about health systems, but even in New Zealand, if you think about the cyclones that happened a year or two ago in this part of the world and East Coast and up north, they had major disruptions for people's health system, for people's health care, their ability to access health care, of course, had also direct impacts on people's health. But not only that, as the world gets warmer, there is going to be an extension of insect vector-borne diseases. Things like malaria will tend to start happening in countries where it's never happened before. And we expect that to be so in countries like New Zealand over time. We can also see climate change playing out for our Pacific neighbours, where literally some of the islands in the Pacific are disappearing underwater. So clearly there's really no greater risk to health systems than that. This one, you might wonder why I put a slide about Russian male life expectancy. Almost guaranteed you didn't expect to see that. But what this shows, this is life expectancy for, as you can see, Russian men from 1950 through to 2007. And what you can see at this point, where that arrow is a sudden drop in life expectancy. So what happened then? In 1991, there was a collapse of the Soviet Union. And that resulted in major social, economic and political upheaval in the Soviet Union, now Russia. And as a direct result of that, there was a measurable and marked decrease in life expectancy. That's how quickly that kind of upheaval impacted people's health at the most extreme level. We're talking life expectancy. Now, if you look closely at that, like what is it that is killing men at that point? It was vodka. And although, that's kind of funny, it's kind of not as well. So life was so difficult at that point because of people were living in poverty, everything was up in the air, there was economically, politically, socially, it was really unstable. People were just taking to drink and it was killing them. And you saw that sharp decline in life expectancy. So the environment in which we live at a social, political and economic level has a direct and measurable impact on health. And if you think New Zealand's any different, here's life expectancy in New Zealand. So this is now 1950s through to 2010, so similar sort of time frame. You've got 4 lines there. The top green line with the little squares or diamonds, that line is non-Māori women. The next line down is non-Māori men. The line below that, Māori women, and the line below that, Māori men. So there's a couple of things to note there. Over all that time, Māori men and women have much lower life expectancy than non-Māori men and women. And that in itself is due to social, political and economic factors. But the other thing you can see is something happened in the early 90s. So you can see if you look at the 2 lines at the bottom, the Māori men and Māori women, their life expectancy was tracking up and the gap between Māori and non-Māori was starting to close. But something happened and suddenly there was a flattening of life expectancy for Māori, and so the gap started opening up. What happened in 1991 was the mother of all budgets. That's when benefits were cut, there was a privatisation of social services, and there was massive increase in unemployment. And so those people who are sort of at the bottom or the most vulnerable in society are those that will pay the cost. So you can see there that there was a measurable drop-off in life expectancy for Māori at that time. Okay, so that's a move on from the social, economic and political environment and talk about the cost of healthcare. We hear about that a lot. There's this really good, useful book written by this guy called William Beaumont. And he was looking at why is it that computers get cheaper and healthcare doesn't. So there's something called Moore's Law, M-O-O-R-E-S, Moore's Law. And basically it says that the capability of computers gets exponentially better and also cheaper. So you get more and more and more for less and less and less. And if you think about what you had to pay for a computer that might fill an entire room, 20 years ago, you carry more than that power in your phone now, even if you've got the most basic of phones. So computers get better and better and better and get cheaper and cheaper and cheaper, but healthcare doesn't. It doesn't get cheaper. It gets more and more and more expensive. Why is that? So one of the reasons is that healthcare is, of course, innately about people. So if you need your wound dressing changed, you need a nurse to change your wound dressing. You need a person. You need a person in healthcare almost always. And the cost of people keeps going up. And it's very difficult to make that cheaper. You still need a person. So that's part of the problem, but not the only part of the problem. Here's another part. This is called Eroom's Law, which if those of you who are clever will note that Eroom's Law is just Moore's Law backwards. because in medicine we have Eroom's Law. It's like the opposite. We get less and less and less for more and more and more. And this is an example using medicines. So what this graph shows, it shows the cost of developing new medicines. So back in the sort of 1950s-ish, if there was about $1 billion invested in R&D, this is standardised for time, so $1 billion for, I think it was for at $2016 or $2,000 or something, but $1 billion spent in 1950, we got something around about 50 new medicines. Now we are well under one, so we might get about half a medicine for the $1 billion that we invest. So we're getting less for more. The opposite of Moore's law. And when we look at that in relation just to cancer medicines, this is the cost of cancer medicines for a month of treatment, again over time. Now the first thing to note is that the y-axis, the one that goes up, is on a logarithmic scale. Now just on the off chance that some of you haven't thought about logarithmic scales for a while, what that means is it goes up by a factor of 10 every time you go up one. So it's $1 to $10 to $100 to $1,000 to $10,000 to $100,000. So if you put this just on a normal scale, that axis would be very big, very long. And again, you're looking over time, the cost per month of cancer treatment. So what you can see in sort of the 70s or 80s, the cost for a month of cancer treatment was somewhere between $10 and $1,000. Now we're looking at a whole cluster of medicines which are around the $10,000 per month of treatment. So this is standardised dollars. So that's a huge difference in cost. Now the treatments are much better and the outcomes are much better. So we get much better outcomes as well, but the cost has gone up multiple orders of magnitude. It's not just gone up a little bit, it's multiple orders of magnitude, which means that it's impossible for any health system to keep up with that increase in cost. Okay, another problem we have in New Zealand and in all high-income countries like New Zealand is growing and ageing populations. So the graph on the left just shows the size of the New Zealand population over time, and it's just growing. The population's getting bigger. But the graph on the right shows something else important, and particularly I want you to look at the dark blue line that starts at the bottom there on the left of that graph. It starts at sitting around about 10%, and it goes up. That is the proportion of people in the population who are aged over 65. So back in 1950, something under 10% of the population was aged over 65. By 2070, we were expecting somewhere between a quarter and a third of the population to be aged over 65. Well, why is that important? Generally speaking, those aged over 65 have higher healthcare needs than those under 65. So that means we've got a much bigger proportion of the population needing healthcare services over time. A bigger population and a higher proportion in that older age group. And in fact, if you look at the eldest older people, the increase is even more rapid than that. It's good news. It's because we've got longer life expectancy. It's good stuff. But it costs more. Here's another issue. Workforce crisis. You hear a lot about these. You might think from what you hear that this is a New Zealand issue, but it's not a New Zealand issue, it's a global issue. So there is a global healthcare workforce problem. It's estimated that we are down about 18 million health workers around the world. Now in high-income countries like New Zealand, we might think we have a health workforce crisis, but it's nothing compared with countries, the low and middle income countries, where they are really struggling. And they're partly really struggling because the health workforce that are trained in those countries, they tend to move from those countries to the high income countries because they can earn a lot more money. So those countries continually struggle. But it's also difficult even for the high income countries. This is a global phenomenon. This was my predecessor, you may remember him. He had to deal with a pandemic. That was also a bit of a problem for health systems, and there is a hangover still from that. There's health systems all over the world are still grappling with the after effects of the pandemic. In New Zealand, we also had a health system reform. So health system reform, I'm not going to go into any detail of this, but it involved merging 27 separate organisations into one. So we've gone from 20 DHBs and 7 other organisations into one, which is Health New Zealand. Now, there are very good reasons for that. It was to provide nationally consistent care, making sure that we had quality care across the country, making sure that there was consistency, and making sure that patient voice was more incorporated into the system. That was kind of the rationale for the reforms. But of course, merging 27 organisations together is a very, very major undertaking. And the complexity and challenge of successfully doing that cannot be overstated. And the final challenge is the fiscal challenge, which is, we've heard a lot about. The government, there's not much money around. There's just not much money around at the moment. So that's all a bit depressing. I don't know how many people here watch Game of Thrones. I don't know, are you Game of Thrones people? I'm getting, most people go, no. There's one up there. She knows what I'm talking about. So winter is coming. This was a thing that that series talked a lot about. Winter is coming. It's bad news. So the question is, when you've got a big, apparently unsolvable set of problems, what can we do as leaders to move forward? So as hopefully made it really clear, the health system is facing some massive, complex problems that cannot be solved in weeks or months or even years. So what do we do? We can't solve our problems with the same thinking we used to create them. I'm quoting Albert Einstein. So the question is, particularly as researchers, or people supporting research, or people who use the outcomes of research, what is it that we can do to make a difference? Which brings me to the second part of my talk, which is kind of my professional journey of how I got to where I've got to. Which is a big question mark. Not so much where I got to, although that is also a big question mark. But anyway, let's put that to one side. Look, I started out as a clinical doctor. This is me in Palmerston North Hospital. That's me there. You probably can't see me. I'm rocking a sort of 90s haircut, which isn't that different to my haircut now, to be fair. We all had white coats in those days, and we all had probably used tissues in our pockets and stethoscopes that we never cleaned and goodness knows what. Those were also the good old days. So I was a doctor, I saw patients, which was a huge privilege. And I think at that stage, I didn't see that I was part of any solutions to any of the problems that I saw in the health system. I was doing my job, I was seeing patients I was doing what I could for the person in front of me. So I call that there's nothing I can do about it, period. But then I moved into academia. I became a public health physician. Apologies, but I worked at the University of Otago. Best medical school in the country. No, joking, I'm joking. That's me there. So I call this the publish it and it will change period. So I don't know, I published a couple of hundred academic papers in this period. I sat on lots of committees, lots of national level committees. I provided a lot of advice to governments. There were a lot of calls to action, a lot of you really should do better, a lot of, that kind of thing. And after quite a few years there, I was a professor and I was doing a lot of global work and I was feeling quite, smug about myself. But then when I thought about it, I thought, what could I say that I've actually done that's actually made a difference? And the best I could say is maybe some of this work has maybe had something to do with something, maybe. But maybe I could never really say, as a result of this thing changed. So I got to thinking, well, actually, before I get to my next phase, I thought I'd better present something about some research that I did during those days, given that this is a research meeting. This was one of the pieces of work I did at that stage. This was early research, some of the first research that looked at why Māori patients had worse outcomes than non-Māori patients with cancer. So what we looked at, we did a detailed study of patients with bowel cancer. And we looked at patients specifically with stage 3 bowel cancer, for which chemotherapy would typically be given. And we looked at the proportion of patients for each step of the pathway from getting that diagnosis to getting the chemotherapy. And you can see Māori on the left and non-Māori on the right. So what you can see, I don't think I've got a pointer, but hopefully you can follow, in the very pale yellowy green at the beginning, that's the proportion of patients that were referred to an oncologist. And you can see that there was just a slightly lower proportion of Māori patients that were referred than non-Māori. And then of those, what proportion were reviewed by an oncologist? And you can see, again, Māori just a little bit less likely to be reviewed. And then offered chemotherapy. Māori patients a bit less likely to be offered. Receiving chemotherapy, Māori patients a bit less likely to receive it. And then starting within 8 weeks, which was what was recommended, Māori less likely. So at each step of the pathway, the difference wasn't great, but the cumulative effect over each of those steps, with Māori just doing a little bit worse at every step, meant that Māori did much worse in terms of receiving chemotherapy within 8 weeks. And that had an impact on whether or not they survived their cancer. So that research was at the time, quite groundbreaking and probably did have some effect. We also looked at the difference in survival between Māori and non-Māori patients. So this slide shows a whole range of different types of cancers. You can see them listed down the left-hand side there. Pretty much, lots of different types of cancers. The red line that goes down the middle of the graph is the line at which, if Māori patients had exactly the same survival as non-Māori patients, all the bars would just sit there. So if there was no difference, you wouldn't see any lines extending to the right or extending to the left. They'd all just be sitting on the red line. The extent to which you see those black lines extending off to the right is the extent to which Māori had worse survival than non-Māori patients. And the extent to which the black lines extend to the left are the extent to which non-Māori patients had worse survival. And what you can see for that is just about for every single cancer, Māori patients had worse survival. We also looked at the impact of other diseases on cancer treatment and cancer outcomes. This is, again, just an example of that. This is for patients with a range of cancers, again, listed down the left-hand side there. And it's the proportion of patients who had diabetes. And you can see that the Māori patients in red were much more likely to have diabetes when they were diagnosed with their cancer than non-Māori patients. And this is important because diabetes can have an impact on whether cancer treatment is effective and can have a direct impact on how quickly cancer grows. So this is an important issue that needs to be managed and addressed in the treatment of cancers. So I'd done quite a lot of work on cancer. I'd looked at the health system. I'd looked at treatment aspects of treatment. I've looked at how we could improve cancer treatment services. I've just highlighted a couple of issues relating to inequities in cancer outcomes, just to give you a bit of a taste of that. But also, by the time we got to about 2017, I was deeply concerned about the state of cancer care in New Zealand. Why? Because cancer was and is the leading cause of death in New Zealand. We were expecting to see a 40% increase in the number of cancer cases between 2020 and 2040. That's actually a very short time period. There were and are long-standing and persistent inequities between different population groups in terms of who gets cancer and who survives cancer. The costs and complexity of cancer diagnosis and treatment is continuing to get increasingly and exponentially more expensive. And survival in New Zealand, cancer survival in New Zealand was improving, but it wasn't improving anywhere near as quickly as other comparable countries. So we were starting to fall behind. So I was doing quite a lot of work internationally at this point, and what became clear is that countries that had a cancer control agency, a central entity that was responsible for making sure that cancer care was high quality, those countries tended to have better outcomes than countries that did not. So I moved into my how do we get the action we need period. And I sat and worked with some colleagues about how do we actually get a change? How do we actually move things forward in this country? It doesn't involve publishing another paper or joining another committee or having another call to action, which everybody ignores. And these are the 7 steps we came up with. The first one is be clear what your problem is. So in this case, we're going backwards in relation to cancer in New Zealand. The second thing is cultivate relationships, collaborate. So all the work that I'm going to just highlight now was done in partnership with patients, with clinicians, with policymakers, to some degree with politicians. You know, there were a lot of people involved and they all had different roles. You have to be able to communicate well. I've done a lot of work in my time with someone called Dr Chris Jackson, who is quite often in the media. He's an oncologist in Dunedin. He's a really amazing communicator. We used to throw him up to the media because he was just did such a good job with that. We were clear that we needed to identify those with the power to act. So if we wanted a cancer control agency, that was the Prime Minister and the Minister of Health. We needed to get their attention. We needed to look for opportunities, and lacking that, we needed to create them. So we did that, and I'll tell you what we did one of the things we did anyway, to create an opportunity. We also had to be very clear what drives decision makers. Now, if you're dealing with politicians, what drives them are things like whether or not the people of New Zealand care about this thing, whether or not if we do this thing, it's likely to get us votes, whether or not it aligns with our kind of political philosophy. You know, those are the things that are going to matter to a politician. And also identify solutions. So going to a decision maker and saying, here's a really big problem, you should fix it, is not very helpful. So we did this. We had a conference. Now that doesn't seem like a very big thing, but this conference was a couple of years in the making. What we did first is we did a lot of communicating to the media. We got the story out. We made it really clear that this was a problem. It was a problem we needed to fix. So in the month before the conference, for example, there was a cover story from The Listener that talked about the issues that we were dealing with. But there was lots of other stuff that we were doing behind the scenes as well. The conference involved clinicians from across the cancer spectrum, from prevention through to palliative care and everything in between. The then Director General of Health, Ashley Bloomfield, was there. The then Minister of Health, David Clark, was there. And the conference was opened by these two extraordinary people, Missy and Blair Vining. Blair was a young man who'd been diagnosed with stage 4 bowel cancer. He was dying. He has subsequently died. And they did the most extraordinary opening to this conference, basically calling out the then government and previous governments for not taking appropriate action for cancer. By the end of the second day of the conference, the government had committed to a cancer action plan. We didn't stop there. There was a petition that was led by Blair to government saying we need a cancer control agency. And we also did a lot of communicating out to the health sector, directly to the health sector. 6 months later, there was an announcement from government that there would be a cancer control agency. I was then asked to be the chief executive of the cancer control agency. That was not part of my plan. That was really not part of my plan. So I said, look, I'll do it for a couple of months and then I'll hand it over. And then I started, and then there was a pandemic, and then I stayed. So I found myself going into the next phase of my career, which is how to do everything all at once period. Now, you can see me there. You just need to look at that photo to kind of get in the headspace. It was really hard. That photo at the top there is a meeting that we had. We had a lot of community meetings asking people, what is it that you need to see from the cancer system? So these cancer patients, I think we spoke to about 3,000 people about their experiences. But what was different from moving from a researcher and an academic to being a public servant? So that was the first time I moved into the public service. So that was December 2019. Suddenly, all the changes I was advocating for were my problems to solve. That was annoying. I suddenly became accountable for all aspects of cancer control. So where I was sort of one of the goodies saying, look, you guys, you need to sort it out, suddenly everyone was pointing it to me and going, hurry up. On the first Wednesday, I started on a Monday, on the first Wednesday I had the media ringing me saying, well, what have you done? And I was kind of, well, I found the bathrooms and I've turned my computer on, it's kind of give me a moment. What I also found is that the levers for change were very soft. So people sort of think if you're in that role, you can just go, right, what we're going to do is we're going to put some more money there and we're going to change that there and we'll just fix that and it'll be done. But of course, it's not like that. It's much more difficult to create change, even if you're in those sorts of roles, even if you're the Minister of Health or the Prime Minister, because there are so many competing demands. And most of the work I did as a public service servant was behind the scenes. By definition, you can't go out as a public servant and advocate for things or say, well, I talked to the minister about X and Y, but they're not going to do this thing. You can't do that. Your job is to influence and challenge behind the scenes, but then you have to stay behind the scenes. So it's a different type of role. It's a different type of influence. When you're a researcher and an advocate, you're out there, you can be really loud about it, but you're further away from the kind of the power. Or you can go into the house, you can be part of it, you have much more direct influence, but also you've got to be quiet about it. You can't always say what you want to say. Expectations were always very, very high. So from cancer patients, from cancer charities and NGOs, from clinicians, there were always appropriately very, very high expectations. And the other thing I noticed was strategic thinking and advocacy was very rarely seen, but when it was there, it was very powerful. And what I mean by that, most people when they were advocating for something would say, this is a really big problem, fix it, and then walk away. And that was kind of as far as it went. Now, you would have 10,000 people saying that. That wasn't very helpful because you've got many, many more problems than you've ever got resources to fix. The ones that thought more carefully will go, well, how can I help you to fix this problem? What is it that we need to do? What is it stopping you as a decision maker from fixing this problem? How can I support you? And those advocates, those researchers were really powerful, and we together achieved a lot. So that would be one hint for anybody who's out there doing this kind of work. But research was still really fundamental to what we were doing. So we published a number of papers. This was one about how we weaved equity into the way that we set up Te Aho Te Kahu, the Cancer Control Agency. The reason for this is, as I've already talked about, there are major differences in outcomes for different population groups in New Zealand. That is a problem in and of itself, and one that we should address. But it also suggests that the health system is not working as well as it could do. So if you've got inequity, the system is not working as well as it could do for anyone. So if you start addressing inequities, it tends to improve things for everyone. So it's a really good lens to look at the problems through. We also did a lot of work during COVID. We used a lot of data during COVID to inform us what was happening in relation to cancer treatment. That's a whole other presentation, but we did some work in there, and we published some work which was picked up internationally. But we also used research in a lot of our outputs. So, for example, this was a report that looked at the state of cancer in New Zealand. We used a lot of research to look at who was getting cancer, who was surviving cancer, who was treating cancer, what research was being done in relation to cancer, which allowed us to set a plan going forward. We also did work on cancer prevention, and we did a really detailed analysis with a whole lot of international colleagues on the availability of cancer medicines in New Zealand. And you would have heard a little bit about that in the news of late, and I'm going to just keep moving on. So then, the next phase of my career came. In 2022, I was asked to apply for the role of the Director General of Health. So this shifted me into the how to do everything they want for health period. So, just the photo down the bottom left there is me presenting at the UN on something. And it was one of those kind of how on earth did I get here moments. We literally see the President of France wandering around there, and the Prime Minister from Pakistan, who's subsequently gone AWOL over there, and the Foreign Minister from Russia, who looked like he just stepped out of a James Bond film, sort of glaring at me as I was delivering a country statement which criticised Russia's invasion of Ukraine, and just being slightly worried about what might happen afterwards. Very strange. Not something I ever expected as a doctor. But anyway, so now I'm the Director General of Health in 2022. So what was different from running a cancer agency from being the Director General of Health responsible for the entire health system? Running an entire health system is inherently more political. So I, as Director General of Health, would spend many hours every week with ministers, for example. It's just health is a very, very political thing. There are infinite deserving priorities in health. The advocacy for those priorities is very high. There's lots of advocacy, there's lots of people saying we need more of X, Y, and Z, all of which is deserving and all of which would be high value. But though that advocacy often competes because you can't do everything all at once all the time. The other thing that I kind of reflected on is sometimes you'd see in the media, that there's no action on X, Y, and Z. And what I reflected on was that inaction is usually if people were saying, look, here's a problem and there's nothing happening on it, they would usually put it down to a lack of awareness. The leaders don't know about this important thing, or they're not interested in this important thing, or they just don't care about this important thing. They'd put it down to one of those three things. But actually inaction was almost never those things. In fact, inaction was often not even inaction. There was often a whole lot of stuff going on behind the scenes, which again, you can't really talk about. Things will happen, but they take their time, and you just sort of have to manage that. The other thing when you're in charge of the entire health system is that everyday fires make that longer term thinking much more difficult. And that's true for politicians as well. There's so much on any given day that's happening in a health system that it's really difficult to think about where will we be in 1 year, 5 years, 10 years. And of course, managing through major structural reform adds a whole another layer of complexity. But research continues to make a difference. And I'm just going to flick through these slides reasonably quickly, but just to give you a sense of how research is so important in an organisation like the Ministry of Health, which is the organisation that I led. So I'm using these 4 examples. The first is designing a learning health system, and I'll come back to what that means in a second. Doing research to inform action. So this is actually research that we did or we commissioned, using research to inform policy, and also our role as a ministry to engage internationally to help researchers to be able to do, particularly to get international funding. So a learning health system is something that came out of the US, and it's sort of growing momentum around the world. And basically what it is, it's bringing together research and knowledge from all sorts of places, including, in particular, from patients and people who are using the health system, setting up the systems so that there is automatic feedback into the system so that the system learns from that and continues to improve. So that it's making sure we have data, research, and people's experiences all systematically feeding back into the system. So what we're working on with Health New Zealand is making the New Zealand health system more of a learning system, so it will start improving. The idea of learning health systems, of the benefits, the potential benefits are many. Here are some of them. The idea is to improve patient outcomes and experiences, to get better value for healthcare, to reduce inequities, to reduce the time between when new knowledge is created and it's actually implemented in the health system, and to improve population health in general. I'm going to flick over that one. Clinical trials is an important part of a learning health system. So the importance of clinical trials is that patients who are part of clinical trials tend to do better than patients who aren't. Also, clinicians love being part of clinical trials or running clinical trials. Running clinical trials in New Zealand means that we get evidence that relates to our own health system. So clinical trials are a win-win. Plus, economically, you get a really good, strong return on investment. So both the Ministry and Health New Zealanders and researchers around the country, including Auckland University, working together to really strengthen our capability in this country to engage in clinical trials. We've been pretty bad at this in the past, but this is a real focus for us at the moment. We also have a research and innovation fund, research and evaluation fund at the Ministry of Health. And we've commissioned a whole lot of research on things like the COVID-19 response, on getting immunisation rates up, on the health and wellbeing impacts of Cyclone Gabriel, and also just doing evaluations of work that's out there and ongoing to make sure that we are learning from what we're doing in the health system. And the final example is Horizon Europe. So we have now joined Horizon Europe. This is an EU huge program. Their budget is 90 billion New Zealand dollars. 90 billion New Zealand dollars. So that is, of course, beyond our wildest imaginings. So it's really useful if New Zealand researchers can start accessing some of that. So we have engaged with the EU. We are now members of this, which means that New Zealand researchers can apply for research from that fund. So we are involved currently with 2 partnership programs. One's about pandemic preparedness and one's about brain health. And there'll be more coming online in due course. But for obvious reasons, this is a huge benefit to New Zealand to be able to link up, work with other researchers and have access to that sort of research funding. So, deep breath. In conclusion, look, first of all, I just want to thank you for your contributions to our health system, both through research and through contributions to research, financial or otherwise. Turning research into action is a challenge, but it is one that we have to embrace if we're going to deal with those challenges that I outlined at the beginning of this talk. Building our capacity and capability to use evidence is critical for us having a smarter, healthier, more effective, more efficient and better health system for all. And innovation is a real driver to make the best use of what are always going to be scarce resources. And my final slide is that one. I wasn't expecting to put that slide in here, but there you have it. So my current steps, next steps, we'll wait and see. That's my next talk. But thank you very much.
It's now time for questions and answers.
I just want to ask you, you showed that the results for Maori people was much worse in cancer treatments and stuff, but it didn't actually cover or explain, is it because they don't go to a doctor early enough, or they're not near doctors, or they don't like to go and see doctors, if supposedly doctors and healthcare is technically relatively close to free?
No, is the short answer. That's not the reason. So we looked at that. We looked at people not, for example, declining treatment and, that sort of thing. There weren't big differences between Māori and non-Māori in that regard. And then we looked, for example, the slide I showed you, which was one particular type of bowel cancer, the stage 3. So they're all at the same stage at the beginning of that time. They're all in the health system. And what we found was that difference, and it could not be explained by any of those things. So, but those things are also important. They can be also important for other things. For example, if you live a long way away from a GP or a long way away from, if you live rurally, those things can also act as barriers. So there is also that. But separate to that, there is something else that goes on.
Really, really inspiring and elucidating. So I work in the rare disease space in Department of Neurology now. However, I have had a history in diabetes and cancer research. So I've worked as a basic scientist and I now work in health clinical research. And what really astounded me is all those years where I worked as a basic scientist, like in the discovery phase and maybe even moving through development, only to find that often, there isn't the funding for drugs that have the ability to help people, and that was eye-opening. So perhaps just a comment from you on, is there anything we can do to gently push for better distribution of drugs that are known to work well for use in New Zealand?
Just to be clear, are you talking about the development of new drugs or the distribution of drugs that already exist that are shown to be effective? The latter, thank you, yeah. We have Pharmac in New Zealand, and the purpose of Pharmac is to make sure we have the most effective medicines available within a given budget. So that, that they're constrained by the budget that they have. What that means is that we tend to get very good prices for medicines in general compared with many other countries, but we do also tend to be price takers in a way. So one of the problems we have globally is that the US market tends to set the prices. And the US had up until very recently, a very odd way of doing that. So what used to be the case, and I'll use cancer medicines as an example, is their Medicare and Medicaid, like the part of their health system that looked after people aged over 65 or people that were below a certain level of poverty, they were required to fund any medicine that had been approved by their regulator, regardless of the cost, which meant that you can imagine what effect that had. The companies just went, right, well, it's going to cost this much then. And the trouble is, once you've got that market, it has this huge impact on the rest of the global market for medicines. So one of the statistics that I find really interesting is the cost of a given cancer medicine in particular, because most of the new medicines, they're disproportionately cancer medicines. The cost of a new cancer medicine is completely unrelated to the cost of R&D, so the cost of developing it, the cost of manufacturing it, or how good it is. Unrelated to any of those three things. It's very hard to think of anything else that's not related to the cost of developing it, the cost of making it, or how good it is. The only thing it's related to is how much Americans will pay for it. And so this is part of the problem we have. And so going back to your question, we can never afford all the medicines in general, cancer medicine specifically, but medicines in general. And it again is a global issue. It needs a kind of a global response, because you end up with this ridiculous thing where people can charge whatever they like, and it basically means that countries can't afford to buy sometimes effective medicines, which is why we have something like Pharmac, and every country has a different approach, but all countries have to limit the number of medicines they can buy just because you can't afford to buy them all.
Just a simple question, and that is looking at what society needs to have: health, housing and education. Can you make money out of health? And it seemed to me that what changed a number of years ago, like 30, 40 years ago, was that people started to look at health as a business, as opposed to something that should be provided for everybody, and that the only way you could make money out of health would be in a 20 or 30 year time frame with preventative approach.
I mean, again, the short answer is, of course, yes, you can make money out of health. And in fact, the example I just gave of pharmaceutical companies, and don't get me wrong, we need pharmaceutical companies to be creating new medicines, but they make a lot of money out of people's poor health. But so do many others. So certainly there is a whole lot of ways of making money out of health, and I guess there always will be. We have a system in New Zealand, as you know, that we have private healthcare, we have public healthcare, and we also have private provision of healthcare, and so there is that kind of dual system. And of course, private provision does involve making money. That's what private provision is. I don't think I can comment much more, but to say that yes, it is there are financial gains to be made from health.
Thank you, that was great. You were talking about research base, the research needed to support things that are done. And to a degree, the most destructive thing that's happened to us in the last few years from both service provision and morale has been the changes for Health New Zealand. Do you think there was a solid research base that supported the degree of change that's been pushed through with Health New Zealand the way it is?
I mean, I think, the short answer to that is no, although it would be difficult to have a research base for a change that size. I think, though, that incorporating elements of evaluation, I guess that's where a learning health system, so we can actually understand what's happening in the health system in order to be able to make it better, is an important aspect of that. Any change of that scale is going to be many years before it settles down, and we're certainly seeing that play out. It's, I agree with you. It's the the changes have been disruptive and are challenging, but there is also opportunity there. And it's how do we create the opportunity? How do we find those opportunities? And how do we shift from this kind of negative spiral to a positive one? And I guess that's the challenge at this point.
Last question.
Thank you very much. That was very interesting, Dr. Sarfati. Given advances in technology and medical research, why is the complexity of cancer diagnosis increasing exponentially?
Oh, just there are so many different ways of diagnosing cancer now, and there are so many different tests. There's all the genomic tests that are available, as well as imaging, different types of imaging. So there's a lot more complexity. So before, back in the day, you might have lung cancer. Now you have, a very specific genomic diagnosis for a particular cancer, which is then aligned for a very specific treatment. And so that in itself is expensive. I mean, it means that we get better diagnosis and better treatment, so better outcomes, but it's more complex and it's more expensive.
So you would say the classification of cancer is becoming more specific? Yeah,
just the whole process of diagnosis, because it gets down to that sort of level of detail, yeah.
Okay, that makes sense. Thank you.
Ngā mihi, Diana, that was fantastic, especially liked hearing your perspective and your stories. You mentioned that your very first period was kind of this, there's nothing I can do mindset, and you were only doing what you could for the patient in front of you. I was wondering what contributed to that shift in that mindset.
I really loved working with patients, and as I said, it was a huge privilege, but I did get a sense that I was kind of on a bit of a treadmill, and that I was seeing people and you'd have people coming back into hospital and back into hospital, and I sort of got to thinking, how do we actually shift the dial? How do we shift the whole dial? And I think my thinking started going down that track, and I started getting into public health medicine. I'm not sure there was a day when I went, that's the end of that, and now I'm going to do this. It was kind of more of a sort of a journey. But I think that was kind of where my mind went, and the rest is history.
Could I ask to think of another way about making money in health? If budgets weren't siloed, surely public health can lead in showing that good health outcomes save the country money overall.
Yes.
Would you like to?
Yes, well, that's absolutely right. And actually, that's one, I was sort of saying that everyday crises in health make it quite difficult to have that 5-10 year view. And of course, public health, like preventive care, for want of a better term, keeping people healthy, the benefits from that come down the track. And a success in public health is when something doesn't happen, which is really difficult to say, I saved your life because you stopped smoking because we did something and you stopped smoking. You don't know that, you just carry on. And so it's quite unsexy. Prevention is quite unsexy, and it doesn't sell very well politically. It's quite hard to sell it. But you're absolutely right that because of the challenges that I was talking about, one of the things we have to embrace is keeping people well. It's better for all of us. I mean, we want to be well, but also it's better for the health system. You get a huge economic benefit from it as well, but it just isn't very easy to sell because of the long-term benefits and the fact that it doesn't fit very well in a parliamentary term, for example. But I mean, I completely agree with you.
I can't tell you how lucky we were to have Diana here tonight. She's given us so much to think about, and the biggest thing I think we can all take away is that we're part of the solution to the problems, and we all need to put thought into that and how we deal with it and what we do. So a huge thank you from all of us, Diana. But I hope you'll all agree that the calibre of presentations and the research that has been shared tonight is absolutely world class. Thank you very much. Thank you to our wonderful 3 presenters, and thank you everybody for coming, and we hope we will see you at the next event on May 22nd. There's information available on that. Another exciting speaker series too. Thank you so much.